to the next session for day 2 at Dr. S. Badrinath Hall. I would like to take the honor to invite our esteemed chairpersons. I welcome Dr. Pradeep Sharma as the chairperson and Dr. Ramesh K for co-chairing the session. And as the moderator, I would like to invite Dr. Rashmin Gandhi. Over to you, Dr. Rashmin. Please take it forward.
Thank you. Thank you so much, and welcome you all to this 1 hour of Neuroophthalmology session. It's a pleasure to have Dr. Pradeep Sharma and Dr. Ramesh as our chairpersons. And let's start with our first talk. We're extremely lucky to have Dr. Clement Tan, who is joining us from Singapore. Clement is a consultant at National University of Singapore, and he also goes to Alexandra Hospital, and he has participated in our Indian Neuroophthalmology Society meetings quite a few times and is a popular speaker in this part of the world. So Clement has sent his recording and he's also present here to take questions. So I request the organizer to first play his keynote lecture, and then we'll have a discussion with Clement.
Good afternoon. I'd like to thank the Telangana Ophthalmological Society for this kind invitation and the honor to give this presentation at your society meeting. I bring you greetings from the National University Hospital in Singapore. The title of my talk is Why We Consistently Have to Change Our Thinking About Optic Neuritis. I have no relevant financial disclosures. What is optic neuritis? It's an inflammation of the optic nerve. Patients present with acute or subacute visual loss, visual field defects, color vision loss. They have an afferent pupillary defect. They may or may not have this swelling, and they may or may not have pain in the eye. What is important though is getting an MRI scan that shows contrast enhancement of the optic nerve, because there are patients who present with similar symptoms and signs who may just simply have ischemic optic neuropathy or labor, for example. This would be a typical patient who presents with a bit of this swelling with some visual field loss. And when we do the MRI, you see contrast enhancement of a long segment of his right optic nerve. Why is it important that we know this subject well? Well, optic neuritis is the second most common acquired optic neuropathy in persons younger than 50 years of age after glaucoma. But there are effective treatments. However, the effective treatment depends on whether we get the diagnosis right and whether we get the patient treated in a timely manner. Failure to do either may lead to a poorer visual outcome. And just as there are many different mango varieties and they have all different characteristics and they taste different, I'm told that the Totapuri is the mango variety that's native to Telangana state. Rashmin, please do correct me later if I'm wrong. But in the same way as there are different mango varieties and they taste different, there are many varieties or causes of optic nerve inflammation. And getting the right diagnosis is important so that we can give the right treatment. This is how I first learned optic neuritis. There was a typical demyelinating group, which was associated with multiple sclerosis, in which the patients were typically young, Caucasian, and female. They had pain on eye movements, typically more than 90%. 2/3 had a normal disc appearance. And whether they were treated or not at the initial stage, they tended to recover starting at 2 weeks from onset of disease and going all the way up to 1 year, and all had a relatively good visual prognosis. The optic neuritis treatment trial, which lasted a really long time, 20 years, showed us that IV methylprednisolone hastens the initial recovery and lowers the recurrence rate in the first 2 years. And this is what we used to tell the patients all the time when they presented with a typical, what was called a typical optic neuritis, that they didn't need an MRI, they didn't need a lumbar puncture, and it was really up to them whether they wanted to have IV methylprednisolone. What the ONTT also told us was that it was not a good idea to give them oral prednisolone because the recurrence rate was higher in the first 2 years. So it was either no treatment or IV methylprednisolone for 3 days, followed by another 11 days of a tailing course of oral prednisolone. 15 years after the first study was published, the follow-up study, the 15-year follow-up for multiple sclerosis in optic neuritis was published, and the ONTT then showed us that if there was even one brain lesion on the MRI at the initial presentation, there was a 75% chance that the patient might wind up with multiple sclerosis. Everything else we called atypical, right? And if the patient was older, the patient was male, there was no pain, if there was this swelling, if the optic neuritis was steroid responsive or steroid dependent, if there's variable recovery, we just said this is atypical. And in this group, there were a few conditions which we could identify with some certainty. One was Devic disease, which was defined by bilateral severe optic neuritis with transverse myelitis with very poor outcomes. There was another group, which we called the Asian or Japanese optical spinal MS, because it did behave a little bit like multiple sclerosis, but tended to involve only the optic nerves and the spinal cord. There were other autoimmune diseases like SLE, sarcoid, Wegener's, that also presented with optic neuritis. There was an enigmatic group called chronic relapsing idiopathic optic neuropathy, which was exquisitely steroid dependent and behaved like and needed long-term treatment. And then, of course, there were infections, right, which in presentation was similar to the autoimmune group of optic neuritis. And then we had some new evidence that came about. In 2004, the anti-aquaporin 4 antibody was associated with optic neuritis. And that led to the definition of neuromyelitis optica. In the initial definition in 2006 by Wingerchuk and al., you had to have both optic neuritis as well as transverse myelitis. But 10 years later, it was redefined to just have optic neuritis or transverse myelitis or any one of the typical clinical scenarios with the presence of anti-aquaporin 4 antibodies. And into this group went what we used to call Devic disease and Asian optical spinal MS. These patients were found to have, many of these patients were found to have the anti-aquaporin 4 antibody, and so they were all reclassified. However, there were about 12 to 30% of patients in this NMO SD group, neuromyelitis optical spectrum disorder group, that did not have the anti-aquaporin 4 antibody. So that led to some thinking, right? Was there another disease there that behaved a little bit differently? And in 2015, the anti-MOG antibody was found in some of these, in a number of these patients, and led to another reclassification of this group of patients as having MOG antibody-associated disease. But at the same time, because of the way that the disease behaved, that it was very steroid dependent, tended to be bilateral, and relapsed very quickly once you tailed off the steroids. The group that was previously called CREON was retested, and many of them were found to be MOG antibody positive. So that led to another reclassification. This will become, the importance of this will become apparent later on in this talk. We then discovered that early plex in MOG disease and aquaporin 4 disease was beneficial for visual recovery. And then more recently, we've discovered new immunosuppressives to prevent relapses. So definitions have changed. And the first definition that has changed that is important for us to understand is the NMO-SD diagnostic criteria of 2015, where you only need one core clinical characteristic and a positive aquaporin 4 IgG test. And the core clinical characteristics are optic neuritis, acute myelitis, area postrema syndrome, acute brainstem syndrome, and some others that are typical of NMO-SD. However, if there's no antibody found, besides, we think about MOG disease, I would think about MOG disease first, but you can still classify them as NMO-SD on the basis of meeting two core clinical characteristics and exclusion of alternative diagnosis such as MOG disease. We mustn't forget MS though, because MS definition also underwent changed in 2017 with the revision of the McDonald criteria. And for me, what was important of this revision was the inclusion of CSF-specific oligoclonal bands as a criteria for diagnosis. Previously, it had been excluded. And so you can see that the textbook has been somewhat rewritten. You have 3 distinct diseases under autoimmune demyelinating or myelin-affecting optic neuritis: MS, NMOSD, MOG-AD. MS is more common in the Western Hemisphere. NMOSD, including MOG, is more common in Asia and is less common in the Western Hemisphere. You can see that there are quite a number of differences. Gender differences. You have more women in MS and NMOSD, but less so in MOG. Children tend to be involved in MOG disease. Pain on eye movements is seen in MS and MOG, but not so much in aquaporin 4 disease. Bilateral disease is, if you have bilateral disease, think NMOSD or MOG. If there is severe vision loss, think NMOSD and MOG. If there is recurrence, right? If you have a lot of recurrence, think NMOSD and especially MOG. Disc swelling is seen more in MOG, seen quite a fair bit in NMOSD, but hardly seen, less so seen in MS. MOG is very steroid dependent. NMOSD tends to be more severe and there's a greater risk of blindness. MOG presents, you may present with ADEM, acute disseminated encephalomyelitis, and brainstem disease. NMOSD has very specific characteristics such as area postrema, and they more commonly have the longitudinally extensive transverse myelitis. The MRI also shows interesting differences in terms of the optic nerve enhancement characteristics. MS tends to have a short segment of the optic nerve involved only. Aquaporin 4 antibody disease, long and posterior, as well as optic chiasm involvement. MOG disease, long and anterior, with perineural, possibly with perineural enhancement and orbital fat stranding. And so these clinical characteristics help us to identify this disease. And so my own thinking on this has changed, and the diseases get reclassified in this table that I keep for myself to help me remember what diseases I should be looking for. The demographics help you by perhaps suggesting what disease you ought to be looking for. Pain may be helpful, not always. Fundus appearance, sometimes helpful. For example, thinking of neuroretinitis. And other features are important because you'd have to ask the patient a history of all these conditions, all these diseases, and search for them with the appropriate investigations. For example, if you're suspecting an infection like syphilis and TB, syphilis, for example, in someone with high-risk sexual behavior, you look for other signs like skin signs on the body, same with SLE and sarcoid. So we need to start off by keeping an open mind about what our patients present with. You notice I've changed the font color for Creon and AON, which is autoimmune optic neuropathy, because I think many of these are being reclassified, and we really should just keep this group to those that fail to meet any of the other criteria. I think we may still have patients that are neither aquaporin 4 nor MOG positive, but may be steroid dependent. We do well to continue to follow them up, and then maybe at some point retest them for the antibodies, but treat them according to their clinical picture. Diagnosis criteria have been revised, and we do want to keep a lookout for revisions in the diagnostic criteria. As I pointed out earlier, the criteria for MS and MOG have changed in recent years, and so we need to keep abreast of this. But we mustn't forget how we diagnose some of the other diseases. Sometimes work with our colleagues from internal medicine and all to get the right diagnosis out. Of importance, as I mentioned at the beginning of the talk, is how we treat them, because you can see that if you give patients the wrong treatment, right, you could end up with a bad outcome. Certainly, if you try to treat an infection with steroids, you might get some initial good outcome, but then you might not be adequately treating the patient if they have an infection such as TB or syphilis. For patients with multiple sclerosis and NMOSD, it's important to make the distinction, because if a patient has MS, they will be in line to get some treatments that prevent relapses, such as interferon, fingolimab, and natalizumab. However, these same treatments may make NMOSD worse. So getting the diagnosis correct, very, very important. Of course, prognosis is important for the patients. They want to know, am I going to retain good vision? Is this going to recur? And so on. We also recently have new treatments for NMOSD. Rituximab, which depletes B cells, inebilizumab, which also depletes B cells but a wider lineage than rituximab, eculizumab, which is anti-complement 5, satralizumab, which is interleukin-6 antagonist. Now, these drugs have all attacked different parts of the pathway, the inflammatory pathway for NMOSD, right? They all are promising and show reduction in relapse rates. Some of them have significant side effects that need to be watched out for, principally risks of infection with encapsulated organisms. But one major disadvantage at the moment is really that they are all very expensive. And so in Asia, this is a challenge because the drugs are so expensive. And so in my thinking through optic neuritis, this is where I've come to. I think of whether this patient has an infection, first of all. And if it doesn't have an infection, then I think, okay, does this patient have multiple sclerosis, NMO, MOG, or some other autoimmune disease? Because remember, when the patient presents to you, you don't know what they have right at the outset. And the challenge really is that even though they are nice diagnostic criteria, in MS, you need to demonstrate dissemination in time and space. And in the first attack, or what they call a clinically isolated syndrome, you have no idea what the patient has. NMO and MOG antibodies take a couple of days in the very fastest of places, and sometimes weeks or months to get a result. So you do not know what the patient has right at the outset. In other autoimmune disease, some of the results will be out quite quickly, right? And they will have other clinical characteristics, and that will be helpful. How to manage this then? So if I have a patient who presents with an optic neuritis, I'll get an MRI done. I need to define that this is an optic neuritis by showing contrast enhancement of the optic nerve. I'd like to look at the brain and the spine to see if there are other characteristic lesions that may help me to put the patient into the correct disease basket. I will test all the patients at the outset for aquaporin 4 and MOG autoantibodies, and I'll test them for all other autoimmune disease, TB and syphilis as well. Because like I said, at the outset, we do not know what the patient has. So I tend to cast my net wide early on so that we don't miss anything. CSF is now useful, not just for detecting oligoclonal bands for the diagnosis of multiple sclerosis, but to exclude infection and sometimes hematological malignancies which may mimic an acute optic neuritis. I have a low threshold for starting my patients on Plex, and I counsel them early that they will, once I found that they have aquaporin 4 MOG antibodies, I counsel them early that they will require long-term immunosuppression, and we consider how we can start this at an early stage. So this is how it will work. Once we've determined that this is not an infection, 3 to 5 days of IV methylprednisolone. I'll start with 3 days, and if there's not much response, I'll go up to 5 days. If there's a good response to steroids, we'll start the patient on oral prednisolone and slowly taper according to their recovery. At this point, I'm thinking, does this patient have MOG disease? Because it responds very quickly to steroids. And if the MOG antibodies come back positive, then we start thinking about long-term immunosuppression to prevent relapses. If there's a poor or modest response, and there are features that suggest multiple sclerosis on the MRI or in the CSF, I will taper the the medicines according to the ONTT regimen of 11 days of steroids, oral steroids, and we'll start thinking about preventive treatments. On the other hand, if there are no typical features for multiple sclerosis, in my mind, I'm still thinking NMOSD or MOG disease. At day 5, if there isn't much visual recovery, I will consider strongly putting the patient on plasma exchange. In places where rituximab is available, this is sometimes the stage at which patients get onto rituximab. But as it's still expensive for us and we don't have that much experience, generally we've been doing plasma exchange and the results have been pretty good. Thereafter, we'll think about when the results come back and they are aquaporin 4 or MOG positive, we think about long-term immunosuppression. Now, although rituximab, inebilizumab, eculizumab, satralizumab, all these drugs that end with ab are not readily available, we still do have some decent drugs to treat the patient with to prevent a relapse, such as azathioprine, mycophenolate. These are not too expensive and they are reasonably good in the prevention of relapse. There are some cases, though, that are quite resistant to it, and for those, we have been doing rituximab at this point in time. Some patients have opted for IVIG, but it is we have to see what the results for IVIG are as we go into the future. And that, in a nutshell, is how we need to keep thinking about optic neuritis into the future. It keeps changing. New drugs come, new definitions come. And with new definitions come a new way to address the disease, and sometimes new ways to treat the disease, and then warnings about how we ought not to treat some of the disease. I hope this has been helpful to you. Thank you for your attention. Have a great conference.
Thank you so much, Clement. Thank you. That was very nicely describing very complicated, if I say, topic, because a lot of times what you have read or what you have understood through the textbooks has all been changing and changing quite rapidly. At this point in time, I also welcome Dr. Ramesh Kekunia, who is joining us from LV Prasad Eye Institute, and Dr. Manju Bhate. Ramesh, Manju, do you have any comments or any questions for Clement?
Not really at this point of time. Clement, very nice talk. I particularly like the table where a lot of things are changing. I don't know, in India, we are seeing more and more of atypical cases than typical cases. Non-infectious, non-multiple sclerosis patients. So it was a great talk.
Exactly. So what has been taught or what we have learned as typical is no longer typical, especially in this part of the world. And what we were told was atypical is becoming more typical for us. Maybe we'll have more discussion at the end of both the other talks. Now I invite Dr. Ramesh Kekunia. He's going to talk about approach to a patient with optic atrophy. Again, a fantastic teacher and a very, very popular consultant. Ramesh?
I will just share my screen. Thank you, Rashmin, and thank you, TOS, for having me today. We are going to talk about some simple topic, but I think this is encountered by many people in the ophthalmic practice. So this is optic dyspallor. How do you classify? This is the most important thing we learn from probably MBBS or first year of ophthalmology. Primary, mainly because of compression, hereditary, toxic, and nutritional. Secondary to papilledema or papillitis or any kind of optic neuritis. And consecutive to some disease, secondary to some retinal disease, or it can happen even after pan-retinal photocoagulation. Sometimes we get the referral from the retinal surgeon saying that optic dyspallor. So optic dyspallor is a sign. We always need to put them into these kind of baskets, whether it's primary, secondary, consecutive, or glaucomatous. And glaucoma is a part of neuro-ophthalmology, even though we have a subspecialty. But as a disease, we ourselves have to classify them and put them into different grades, different etiology, not grades. And there are grades of optic disc pallor as well. So from an ophthalmologist point of view or ophthalmoscopic point of view, pallor can be graded and there could be a differential pallor would be there. Color is very, very important. That's why disc looks pale and immediately let's order MRI. I think that's not a correct way of doing it. We need to see how the vessels emerge from the disc, size of the cup and contour of the cup. Sometimes, many times, in fact, post-neuritic, post-papilloedemetic situation, peripapillary nerve fiber layer, they give a lot of information. And background retina, always do not forget. One of the things, as most of the cataract surgeons in this audience should know, that the optic disc looks different when you have a cataract, when you have aphakia, when you have intraocular lens. That kind of differentiation one should be able to do before putting the patient with the sign of optic disc pallor under investigation. Just for example, this is a primary one. This is a secondary. Look carefully the vessels and the peripapillary area. They are different. With the look only, we can say many times. Look at the consecutive ones where the background retina, there is RPA mottling and other things which are very clear. And glaucomatous, as I said before, it's a very, very different thing. So whenever one looks at the optic disc, remember color, remember cup, remember contour, and remember it's not only optic disc, there are other parts of the retina as well. For example, central foveal area as well as peripheral retina and the background retina. And most importantly, the media with which you see is important. Always, once you have optic disc pallor, if you have clinically classified that, get a visual field, specifically add 10' to this, bitemporal hemianopia, central scotoma, inferior altitudinal defect. You should immediately think of, okay, pallor with bitemporal, I am probably looking at a chiasmal lesion. Central can be anything. It could be post-neuritic. It's a toxic neuropathy. It could be a nutritional. But unlikely that I am looking at a brain lesion. Unlikely. I said it's still possible. When I see this inferior altitudinal, I think more in terms of ischemia, probably if the optic disc is correlated. There is definitely a role of OCT. This is one of the patient of Leber's hereditary optic neuropathy, and see the ganglion cell loss also. This also gives an additional thing. Electroretinography, yes, there is a role, especially with the post-GCA, CRAO, CRVO, and also some of the retinal diseases. VP, in my practice, definitely not much of a role, but post-neuritic optic atrophy, when they come to you, that can have some role. Obviously, the magnetic resonance imaging technique, people used to look at only brain, but try to look at the chiasma, optic nerve, the whole segment of the optic nerve, whether it's hyperintense. See, look at this, right and left, it's different. Immediately, I can say that it's not a tumor, it's an optic neuritis where there is hyperintense areas. Very limited role of CT scan. In extreme cases of trauma, it still has. For me, other ancillary investigations, once you have optic disc pallor, depending upon the situation, depending upon the history, you can look at nutritional profile, blood glucose level, carotid evaluation, and definitely some of the cases are for infective pathology. So causes of pale disc other than optic atrophy, you need to know. Sometimes the disc could be very large. Sometimes it could be myopic disc. It depends upon the luminosity. So you need to remember this. Sometimes it could be hypoplasia, and sometimes it could be other congenital anomalies, for example, optic disc pit. So please do not confuse them, even the optic disc coloboma with the optic disc pallor. I would suggest everybody to look at this review where what are the glaucoma mimickers? It's the other way we are looking at, some of the peripapillary areas, looking at the notch here, looking at the NFL layer in the third picture, and small peripapillary kind of, hemorrhage here, pallor, all that becomes very, very important. You need to look at every one of these things. But sometimes a combination of everything can give you a diagnosis, be it peripapillary vascular changes, optic disc fade, morning glory syndrome, or inferior altitudinal defect, OCT. Multimodal imaging can help us in some of the difficult cases when you can't arrive. And this is a 6-year-old boy. I'm just giving an example. His vision is 20/25, but he is bumping into objects. His retina is normal. But when you see this kind of inferior altitudinal, remember, most common, especially in our practice, is hypoxia, hypoxic-related damage to the brain. So he had a cord around the neck and fetal distress. And you can see sometimes how useful the multimodal imaging, be it drusen, be it toxic neuropathy. In the upper picture, you can see this drusen very clearly with the autofluorescence as well as D-scan, as well as they can also have visual field defect. And this is another example, typical superior segmental pallor with peripapillary changes in the upper picture with inferior altitudinal kind of field defect, you can see, and superior segment on OCT. And look at even the MGCL, how that segment is correlating. So this way we can really come to a diagnosis. And obviously this I should not tell. Visual field, for me, the relative afferent pupillary defect and visual field are the most important ancillary tests when you have optic disc pallor. Obviously, there are other tests like color vision and other things, but these are the important things. And if you look at, this is a slide given by Dr. Sachdeva. If you look at the various shades of gray, important patterns, when you have asymmetric temporal pallor, as I showed this case, excuse me, earlier, this patient has bitemporal hemianopia, typically a chiasmal compression. And if you see this patient, optic disc pallor with the thready-like vessels, background retinal changes. It could be post-vascular occlusion, specifically CRAO, or also sometimes it can be seen in ischemic optic neuropathy. This pallor with glyoti changes and peripapillary changes, if you see a lot of atrophy around it, watershed kind of situation, it could be because of chronic papilledema. Obviously, retinal anomalies, any kind of abnormalities, severe abnormality can lead to consecutive optic atrophy. So remember, retinal conditions and metabolic. Typical, many of the clinic, we say patient has temporal pallor. I would like all of you to remember two things. One is do the visual field that will show central or centrocecal scotoma. There are 4 differential diagnoses: nutritional, toxic, hereditary, and obviously post-optic neuritis. These are the 4 things you need to remember in a typical temporal pallor. I'm not saying other things are not possible, but generally if you rule out these 4 things, you will be on a correct track. And always examine the face, look at the face, look for any dysmorphism, examine family members, especially with the optic disc pallor in the child or even in adults if there are siblings affected. Look for ocular and systemic association and don't directly jump into neuroorbital imaging. For example, this child has, look at the dysmorphism there. Immediately, if this patient has pallor, you know that it's because of craniosynostosis. This patient has a boat-shaped skull. If you miss seeing this, you might miss this scaphocephaly. Patient had osteopetrosis. Because of that, the patient had. Look at this patient, optic is pallor with lot of calcification along the optic nerve. Typically, this patient has a tram track kind of appearance with the calcinosis. This is neurofibromatosis related glioma for this patient. You can see here. Just whoever likes mnemonic, just remember this mnemonic. It covers vascular, inflammatory, neoplastic, primary demyelinating, idiopathic, traumatic, toxic, congenital, hereditary, and metabolic and endocrine causes and degenerative. This looks easy on the slide, but you need to concentrate on history, examination of the optic disc per se, and then ancillary test. Thank you very much for this opportunity, Rashmin. If there are any questions, I can take now or even later.
Thank you very much. A wonderful conclusion and a really nice flowchart of how to approach to a patient with optic atrophy. Let's have Dr. Manju's talk first, and then maybe we can come back to the question. Manju joins us also from L. Prasad Eye Institute, and she's going to talk about approach to a patient with cranial nerve palsy.
Thank you, Rashmin. I'll just share my screen first. Just give me a second. Okay. Are you able to see my screen?
Yeah, we can. Just start the slideshow.
Yeah. All right. So very good afternoon, everyone. And at the outset, I'd like to thank the organizers for the wonderful conference and for inviting me to participate in this neuroophthalmology session. Okay, so in the next 12 minutes or so, I will be taking you through the approach to patients with cranial nerve palsies, and the cranial nerve palsy is relevant in this topic will be the third, fourth, and sixth cranial nerves that we'll be discussing today. So let's begin with a case. So this is a 43-year-old male patient who presented with the history of horizontal and vertical diplopia. He had decrease in vision in the left eye and drooping of the left upper eyelid, as we can see in this photo over here. He had no history of ocular trauma, surgery, headache, vomiting, or nausea. He used glasses previously, and he was a medically controlled hypertensive. So as we can see in his 9-gaze photo over here, in the primary position, we see a moderate to large angle exotropia of the left eye. Looking at the side gazes, he had limitation of adduction of the left eye. He had full range of abduction. Looking at the up gaze photos, he had limitation of elevation in straight up right and left gazes. And looking at the depression, again, he had limitation of depression of the left eye in straight down right and left gazes. So this patient basically also had involvement of the pupil of his left eye, and his other cranial nerves were intact. So with a working diagnosis of a left pupil involving partial third cranial nerve palsy, the first thing we ordered was an urgent MRI with an MR angio to rule out any aneurysm compressing the third nerve. And sure enough, he did have a posterior communicating artery aneurysm, which we can see very well highlighted here, which was compressing on the third nerve. So just to say that compressive or traumatic optic neuropathies are very important, especially if it's a compressive optic third cranial nerve involvement because of a PC aneurysm, because this is a life-threatening condition. And this is the case where an urgent MRI or an MR angio, CT angio is very much necessary. And in some cases, a pupil involvement may be the first sign, and we just need to watch judiciously to see if there is going to be some limitation of extraocular motility, which may come on in a few hours or perhaps in a couple of days' time. So this is a red flag sign in cases of patients who typically present with partial third cranial nerve palsies and more so involving younger age group. So let's look at another case. This was a young patient who presented after a history of dengue fever a week or two later. He presented with a droopy left upper eyelid and horizontal double vision. We can see an exotropia in this photograph, and his MRI, both the axial and the sagittal images show this well enhanced course of the entire third nerve, which was so to say lit up in the images. Again, we can see it very well in this axial image here. So this basically was an inflammatory third nerve, probably immune related, and we then went on to give this patient oral steroids. I don't know how much of a role it would have had and whether it hastened the recovery, but eventually this patient did have resolution of his signs and symptoms of the partial third cranial nerve involvement. Let's look at another lady. This is a fairly elderly lady who presented again with a partial third cranial nerve. As we can see here, the ptosis and the limitation of elevation, depression, and adduction to some extent of the right eye. She had a fairly large, ill-defined lesion over here, which is involving the orbit, the intracranial, and the cavernous extension, and it was suspected to be an invasive fungal mass or a malignancy, wherein she was again urgently referred for neurosurgical and oncosurgical intervention. So just to highlight, these were just a few cases where the patients presented with a partial third cranial nerve palsy, so as to say if it's a complete ptosis with complete limitation of motility of the muscles which are supplied by the third nerve, especially in an elderly, we think more in terms of an ischemic onset of third cranial nerve. So coming to the approach, again, we start with ruling out the differentials in such conditions, then confirming the working diagnosis, whether it's a partial or a complete third cranial nerve palsy, then looking at the approach to the etiology. So again, we'll go through the surgical sieve of, is this infective, inflammatory, traumatic, compressive, ischemic, or neoplastic condition? Approach to localizing the lesion, as in whether it's an isolated versus a multiple cranial nerve, to try and see which along the course of the nerve where it would have been affected. Then again, approaching the investigation. So blood workup is important. It is necessary, especially in elderly, where we're considering systemic risks. Then neuroimaging, as we've seen in some of these cases previously. So it's important which modality. So MRI is the preferred one, when to request and when to prioritize. Then approach to the management, basically it's more tailor-made depending upon the cause and the residual strabismus. So it can be medically managed based on the cause or surgically. I think the previous session, Dr. Sharma has covered very well about the surgical management, so I won't go into that in constraint of time. We'll move on to the next cranial nerve, the fourth cranial nerve. So let's look at some more cases and how we approach these patients. So this is a young chap who had a fight in the pub. So this is where I was previously working in Sydney, Australia, where there used to be, it was a fairly large trauma center, and there used to be all such kind of cases coming through. So he came in a couple of weeks later with vertical diplopia. As you can see, he's got a right hypertropia of, which is fairly mild to moderate. It's more in the left gaze, and it is more in the right head tilt, as we can see in these photos here. And so he had all the components of the Park 3-step test, so to say. He had a right hyperdeviation. He had increase in the hyperdeviation on left gaze and underaction of the right superior oblique muscle in that position of gaze. So basically, he was concerned both with regards to his cosmesis as well as his diplopia, and he underwent a single muscle inferior oblique recession, which corrected both the deviation in primary as well as the side gazes. So this was another young girl who came in with a left head tilt, as we can see in this photo here. She had a right hypertropia. Again, the hypertropia worsening in the left gaze. She had an underaction of the superior oblique on the right side. She basically had a orbital hemangioma, which was excised, and then it affected the nerve to her right superior oblique muscle. She also underwent surgical correction with a single inferior oblique myectomy. So basically just looking at the components of the the superior oblique palsy. So we look at a vertical diplopia. So we look at a vertical right on left, a right hypertropia. It would, in case of a right fourth nerve, it would typically be worse in left case. So it's getting better now in right case. But as soon as the patient turns his head to left, see, it's much worse, as we can see in this little video clip over here. And so also it would be worse on right tilt as compared to the left. So in this left, it's again less obvious, and it's going to be much more in the right head tilt. So just go on to the next. Coming to the correction again, this depends upon the individual case, the etiology, and the various modalities that we go through treatment. So either occlusion or prisms or observation, or then looking at surgical correction. And very often, if it's a smaller deviation, either just doing a single inferior oblique myectomy, which you can see on the right side, just cutting a stump of the muscle here, and then suturing the conjunctiva and letting the cut ends into the orbit, or actually securing the muscle to the Park's point, which is temporal and slightly inferior to the inferior rectus, just so that if at all we do need this muscle at any point in time later, we know where to get it from. So this is another patient. This basically was kind of, a hefty gentleman who was in the prison for about, for many years. And then one fine day he realized that, he wanted his deviation and his double vision corrected. So he came into the eye clinic. He again had a large right hypertropia. And in addition to his hypertropia worsening in left gaze, he also had limitation of depression, as you can see in straight down gaze. So basically, because of his long-standing hypertropia, he had a contracture of the superior rectus muscle as well. So he had a spread of comitance of his right fourth nerve. And so he needed weakening of both the elevators, the superior rectus and the inferior oblique, to correct his deviation. So localizing the lesion in case of fourth nerve, again, we either look at midbrain, or whether it's at the pons, the cavernous sinus, or the intraorbital portion, and then work out accordingly for isolated ipsilateral, contralateral, or multiple cranial nerve involvement. Again, some of the differentials are common to the other cranial nerves. Skew deviation is an additional thing which we need to look at, typically in fourth cranial nerves. And in cases where closed head trauma, which is the commonest etiology, we need to look at bilateral involvement. And again, the management comes to the same principles: conservative, that is to observe, use occlusion, prisms, or surgical correction, depending upon the patient's requirements. Let's come to the last, that is the sixth cranial nerve. So this little girl presented with diplopia. She also had headaches, limited abduction, as you can see in the side gazes, and vomiting. She had bilateral disc edema. She had hyperemic disc with some splinter hemorrhages. And she had all the telltale signs of raised intracranial pressure. So she had flattening of the globes, kinking of the nerves, and the enlarged perioptic spaces, and transverse sinus limitations. So she had a lumbar puncture where there was raised CSF opening pressure. The CSF analysis was normal. And with a diagnosis of idiopathic intracranial hypertension, she was started on medical management. Sometimes these cases, if there is a threat to vision, also need surgical intervention. This other patient who presented with a right sixth cranial nerve palsy, he has limitation of abduction, as we can see here. He had inflammation in the close to the orbital apex, as diagnosed as a Tolosa-Hunt syndrome case. This another slightly elderly individual with the background of diabetes and hypertension, as we can see, has limitation of abduction of his right eye. He had a right acquired sixth nerve palsy, which is almost complete. And so in each of these cases, we need to work out the etiologies, commonest, whether it is systemic or any other form of etiology, and also look at the course of the nerve, where it is involved, and then approach the patient accordingly. So I'm just going to maybe not cover the surgical part, but there is correction either for the complete. Yeah, and this was a patient with multiple cranial nerves involvement because of COVID. He was another interesting case. So just to conclude, it's important to get to the etiology and order appropriate investigations. The management is usually tailor-made, and preventative measures for recurrence are really important in such cases. Thank you so much.
Thank you, Dr. Bhatte, and that brings us to all three talks, and we had wonderful talks on variety of topics. At this point in time, let me invite Dr. Clement. Your comments, any questions?
Wonderful talks by Ramesh and Manju. I just had one question for Ramesh. I was thinking about a patient I've been referred recently, a child who had optic atrophy and chronic renal failure, and I haven't figured out what he has yet. But the pediatric nephrologist is trying to see if there's any link between optic atrophy and chronic renal failure, and I wonder, because you all see a lot more kids than I do, likely see more kids because you have a wonderful combination of pediatric ophthalmology and neuro-ophthalmology there, so you might see more than me. I wonder what your experience has been in kids with optic atrophy and renal failure.
Yeah, generally, thank you, Clement, for your question. Generally, it is metabolic. You need to look at a few of the things. One of the common things what we see, it's not very common here. We see maybe 2 or 3 per year or so. Methylmalonic aciduria is one of the things we need to see. And generally, there is one more amino acid, the pyruvate acid. These are the 2 things we see with the renal failure. If the patient has any kind of diabetes or diabetes insipidus, then we are definitely looking at Didmore syndrome. That would have been more obvious with your examination, because you would have had deafness and other things. So I would work up for metabolic reasons. It's not consecutive. It's usually metabolic related to the amino acids accumulation in these patients.
Right. Thank you very much. I will. That's wonderful. I will certainly have a go at this and talk to the nephrologist. Thanks very much.
Yeah.
And I was wondering for Manju, as you were talking about some of your cases, for 6 nerve palsies, right? I'm just wondering what your threshold is for performing an MRI or for doing neuroimaging, because that's one of the questions we usually get asked, right? When do you, in a patient with an isolated 6 nerve palsy, when do you decide that you're going to scan the patient? I just wonder if there's any difference in how it's thought of when you practice at Avi Prasad.
Yeah, I think that's a really good question. And basically the principles I would use is essentially the same, as to try and first work out the etiology. And if there is a clear-cut etiology where I know that, yes, this is causing 6 nerve palsy, this is an elderly patient who's got systemic comorbidities, and I mean, I'm pretty much sure that these blood levels are not controlled, and this is what it is. I would not really consider neuroimaging firsthand. But then if I think that things are not improving the way they should in that patient, then that would be something at the back of my mind, definitely. And in any case where I feel that there is a slight doubt as to the cause of the 6 nerve palsy, I would have a lower threshold to neuroimage. I do think sometimes we probably do tend to practice a bit of defensive medicine as well, even if it's India. So yes, there is that element of patient-centric management when it comes to considering neuroimaging as well. Yeah.
Okay, it's glad to know it's not too dissimilar, because for us, sometimes if the neurologist gets to the patient first, they get an MRI before that we can see them.
Yeah. So that does happen in LV Prasad. They do many a times come with some sort of imaging as well. So that's also
very interesting.
We had published a study where we had studied around 150 patients of 6 nerve retrospectively when I was in Chennai. And we had compared it with Andrew Lee's study, which he had studied about the same thing, about neuroimaging in 6 nerve palsy. And what we found is that anybody below the age of 50 in India, irrespective of whether presence or absence of vasculopathic risk factors, they are at a higher risk of having something going on in the brain. And we found these 3 patients in that study where they didn't, they had vasculopathic risk factors, were thought to have a ischemic 6 nerve palsy. They got the MRI and they had basal skull tumor. So we concluded in the study that anybody below the age of 50, irrespective of what factors you may have, you would do MRI. And above 50, obviously, you have to make sure that it's an isolated mononeuropathy, corneal sensation, and everything else is fine. And even then, we generally, if the MRI is not done, then we end up following them up every week to make sure that no other nerve is getting involved in first 2 or 3 weeks. And if anything else is going on, as Manju said, a new onset headache or corneal sensation gone, they will get the MRI. In fact, third nerve, I think more and more people now are here that third nerve, whether people is involved or not involved,
Yeah.
for the neuroimaging for third nerve is really going down now. I don't know what you feel, Ramesh or Clement.
Going down, you mean they're imaging them less often now, third nerves? I would have thought they were imaging them more often.
No, more often. The threshold image.
Yeah, I get. I mean, the threshold for imaging now is lower, and in a way, I think it's a good thing. I mean, because so many things do keep popping up out of the woodwork, and when you're least expecting it, and if one day if MRIs become less expensive, then it'll be like taking a photo, so then we won't worry so much about it. Yeah, I wanted to ask, I did show a table with a lot of causes of optic nerve inflammation, and I always remember that in India things are often a little bit different, and remember that TB is often a big cause of all this, and so I just wonder whether there's been any change in that sense that TB is still quite prevalent in terms of being a cause of acute optic neuropathies.
Very, if I can take that question, very less often, Clement. We don't see in a typical retrobulbar neuritis or papillitis, very less of TB. Probably, I don't remember any case being diagnosed. We are getting more and more of toxic, neuropathies because of TB treatment. Toxic effects are more presenting as optic neuropathy than the real TB itself.
Right.
But having said that, when you have neuroretinitis, at least in our practice, this is an approximation, around 10 to 15% of them are positive for tuberculosis. I'm talking about optic neuritis in a typical neuroretinitis kind of setup, not in retrobulbar neuritis.
Right. Okay, that's most interesting to know. Yeah.
Yeah.
I think Rashmin mentioned it earlier, really, that atypical has now become typical. And I don't know about you, but I really just look for NMO and MOG nowadays as a reflex. It's I don't know if that's the same for all of you. We kind of reflexively look for NMO and MOG now.
So with this NMO, can I just ask you a quick question, Clement?
Sure.
So if sort of, you see a patient, you've started the patient on IV steroids and you're thinking along the lines of atypical optic neuritis, at what time frame would you order the NMO MOG? Like, the patient already on the IV steroids and now
Well, I think if I catch the patient at the outset before the steroids are started, I will send off the NMO and MOG right away. Because first of all, it takes time to come back. Secondly, once you start steroid treatment, your titers may go down, and then you may not catch the NMO or MOG. But irrespective, right? If they've been sent to me from somewhere else, and they've already been on steroid, I'll still send off the NMO and MOG because we are obliged to look for it. In Asia, I think we're now obliged to look for NMO and MOG because it's been shown that they're so common here that we do have to start looking for them. So I will send you straight at presentation NMO and MOG. I think it's probably just, and I'm sure the cost of the tests are really going to come down quickly, and then we'll be able to test everybody freely.
Right.
I think the other important issue is the time, because it takes time before you get the results. So
exactly. So actually the challenge is at day 5, if they're not improving, do you put them on plasma exchange already, because you don't know whether they have NMO and MOG or MOG, right? And then you put them on. I actually had one patient who had MOG, and we hit day 5 and we thought, okay, we'll go to plasma exchange. And after the first cycle of plex, she was well. The vision came back 6.6 and the fuse just improved dramatically. So sometimes you just, it's a matter of when to do it, and it's difficult to know without the results.
Thank you. Thank you so much. Thank you, Dr. Clement. We already have been given a signal that
Yes, I see that.
Thank you so much. Thank you, Ramesh.
Very much for inviting me,
Thank
and it's
you.
been a pleasure being
Thank
with
you,
all of you.
everyone.
Thanks,
See
everyone.
you all.
Thank you.
Wonderful. Very
Thank you.
insightful and comprehensive talks by all our speakers and very well moderated by Dr. Rashmin. Huge thank you to Dr. Pradeep and Dr. Ramesh for chairing the session. Let's have a huge round of applause for all the speakers. For those who haven't turned on the camera, I would request everybody please turn on the camera and unmute your lines. We'll have a huge round of applause for all the speakers who have presented for this session. Great. Maybe we'll wait for a moment for everyone to turn on the cameras. All right. So let's hear it for all the speakers as a virtual photograph. Let's hear it for all of them. All right. Amazing. Thank you.